Staying healthy starts with you, but sometimes you need a partner to keep you on track. Cooper University Healthcare welcomes you to this edition of Healthy You, options for achieving a restful night's sleep.
Hello, everyone, and thank you for attending today's webinar, Options for Achieving a Restful Night's Sleep. Don't we all want that? On NBC10.com, brought to you by Cooper University Healthcare. My name is Pat Shiraki, and I will be your host today, along with Dr. Jonathan Kass, the director of the Cooper Sleep Disorder Center. Also with us is Dr. Donald Solomon, the director of pediatric otolaryngology at Cooper. Today, we're going to cover topics relating to sleep disorders and options for treating them. So, Dr. Kass, let's begin with you. You are a board-certified pulmonologist, the medical director of the Cooper Sleep Disorder Center and the Insomnia Program. Tell me what it was that drew you into treating patients with sleep disorders.
Well, for the average person over their entire life, they sleep about 8 hours, which is about a third of your life. And in medicine, we knew very little about this. It was a new frontier. We know much less about sleep disorders, and that what made me interested in it.
And so, have you found, though, that this is a practice that has grown in interest and breadth?
Yes. When I first started out, there were just a few hundred sleep doctors in the country. And even in my medical school, I had a textbook on sleep disorders, and there was very little in it.
Right. And so we realize now, though, after all this time in research, that sleep is really an important part of keeping us healthy. Dr. Solomon, tell me about your practice, and a lot of it focuses on pediatrics.
That's right. I'm a pediatric ear, nose, and throat surgeon, and so most of the time I'm dealing with kids. My partners actually will be taking care of our adult patients that need surgical intervention with obstructive sleep apnea, and they're very good. Taking care of kids with sleep apnea is actually a little easier than taking care of adults. In children, it's almost always the tonsils and adenoids that are causing the problem. And surgery is the first line treatment, as opposed to adults, where it's often CPAP or continuous positive airway pressure, the masks you see over there to your left, that is the first line treatment, with surgery to augment that. And 90% of the time, if I take out a child's tonsils and adenoids in the right selected group, I'm going to cure their obstructive sleep apnea and the trouble that goes along with that. So my job's actually a little easier than Dr. Kass.
Indeed. So we're going to explain about the masks, and we're going to explain the whole process of what the difference is between the pediatrics and also the adult side. But so let's start, though, with the thing that seems to get everyone's attention, especially with partners in the middle of the night, and that is snoring. Now, what I'm really curious about, can snoring ever be benign?
Well, it depends how much you're snoring and if it's continuous. Some people only snore when they're very tired, or if they've had some alcohol intermittently. Well, that's certainly not a problem. But if you snore continuously and loudly every night, it may be a sign that you have something more serious, which is obstructive sleep apnea.
Okay, so explain to us what obstructive sleep apnea is.
Well, first, I'll start with snoring.
Okay, great.
Snoring is when the airway is when you're wide awake, nobody snores, because you have a muscle in the throat that keeps the airway open. When you go to sleep, this muscle relaxes, and if the airway is narrow and the muscles are floppy, when the lung sucks the air through the narrow floppy space, the soft parts of the nose and the throat vibrate, and that's snoring. So it's a partial obstruction. In sleep apnea, the airway is narrow enough that when the lung sucks the air in, it actually sucks it shut like a straw, and you stop breathing for 10 or 20 seconds.
Wow. And so, I know from a lot of conversation around tables at different times, they say, I hear my husband, it seems like it's particularly that side, I hear my husband stop breathing, and that really scares me. Is that really what sleep apnea is?
Yes. Sometimes, you may hear the bed partner stop breathing, but you may not.
Right.
Depends if you are awake at that point of the time. Some people only stop breathing in the middle of the night or towards the morning when they're in their deeper parts of sleep. And other people stop breathing the entire night.
Right. And so now, in terms of children, is it the same process, Dr. Solomon?
The obstructive sleep apnea process. So snoring and obstructive sleep apnea are all on a continuum of increased upper airway resistance. And if it progresses to the point where you're having apnea, that's where our real problems arise, and that's where when intervention becomes necessary. Snoring can be an issue. No snoring is normal for children, and so you have to begin investigating when you hear that a child is snoring. And snoring can be a problem for both bed partners and the individual themselves, and there are procedures that we can do that address snoring alone versus procedures that we do that address obstructive sleep apnea. Okay. In children, if I'm going to operate, those are kids that I'm either suspicious of obstructive sleep apnea or I have a sleep study that's documented obstructive sleep apnea.
Mm-hmm. And so children go through sleep studies as well?
So the reason to use a sleep study in a child is if you have a child with comorbidities or other medical problems like Down syndrome or craniofacial abnormalities, if the story of apnea is inconsistent with the size of the tonsils and the way their airway looks, or if there's a suspicion that there's apnea present but you're uncertain, there are certain children that I don't need a sleep study to determine if they have sleep apnea. Those kids that come into me with big giant tonsils that obstruct the back of their throat, parents that say they're nervous when they watch their kids sleep because they stop breathing on a regular basis, and then have the other constellation of symptoms that goes along with pediatric obstructive sleep apnea, those children, I often don't need to do a sleep study to make a decision about surgery and help them.
Mm-hmm. All right, so let's talk about adults, and let's talk about the process of diagnosis. So where do you begin with that, Dr. Kass?
Well, you first talk about your symptoms to your primary care doctor, and if your primary care doctor thinks they're significant, they usually will send you to be evaluated by a sleep disorders specialist like myself, and if we agree, then we will order a sleep study. Now, these days there are two types of sleep studies. There is one that can be done in the laboratory where you're hooked up to all kinds of wires and they monitor your sleep and all your breathing and your cardiogram during the night. And there's a newer form where you can have it at home with less wires.
But are they equally effective?
Well, it depends on how bad your sleep apnea is. If you have severe sleep apnea, the home study's been shown to be just as good as the laboratory study. If it's more of the mild variety, there's more variation, and sometimes you can have a normal home study and still have mild sleep apnea in the laboratory.
Okay, so tell me though, what would be symptomatic? How would we know potentially, besides somebody saying to us, a bed partner saying, honey, you kept me up all night, you were snoring, it was really terrible.
So this relates to what happens when you stop breathing. So when you stop breathing at night, your oxygen saturation in your blood decreases. And while you're sleeping, your mind is asleep, but your brain is working. It's pumping the blood, it's breathing, it's doing all kinds of things. And it notices that you're not breathing and your oxygen is low, and it thinks you're being choked. And it sets off a massive alarm. Wow. Adrenaline flows and your heart rate goes up and your blood pressure goes up, and the brain eventually will wake itself up and wake the muscles up in your throat so you can breathe again, but your mind doesn't wake up at all. So you don't know anything about this. Now, if this happens a lot during the night, many times, it gives you poor quality sleep. So when you wake up the next day, you don't feel like you had a good night's sleep. The normal person, when they sleep a whole night, should feel, after they get up and get dressed and washed, should feel refreshed like they've had a good night's sleep. People with sleep apnea wake up non-refreshed. That's one thing. In addition to that, the other problem during the day, and especially during the afternoon, when we all have a little lull and feel a little sleepier, they may feel excessively sleepy and may fall asleep when they're quiet. So not when they're up and about and doing things, but at a meeting or reading or at their computer, they may doze off.
Wow, so that's really very clear. Yeah, and so one of the other things is we were looking at the list, medical family history, a physical exam, sleep studies, a polysonogram. What is that?
A polysonogram is a sleep study. That's the one that's done overnight in the laboratory with all the wires attached.
And then we would also have the home-based study. Right. I just want to make sure that everybody understands, how all of this is diagnosed. So if you have a family member who has had sleep apnea, would you be more likely to have it?
Well, it depends what the reason the family member has sleep apnea with. If the family member, the majority of people with sleep apnea are overweight. So if you are also overweight, then you may have a higher risk. But if you're not overweight, you may not. Another cause is a reset jaw, a small and sort of rounded jaw, which narrows the airspace in the back of the throat. This is always inherited from someone in your family. And so if someone in your family is not overweight and they have a small jaw, then you also have that. Then you will also have an increased risk.
That's so interesting. And does the risk increase as you get older?
Absolutely. What happens is that the tissues in the back of the throat get floppier. The muscles, it's an aging process just like the rest of the body. The skin is not as taut and when you get older as when you're younger. And the same thing happens, you don't see it.
This is so inspirational to hear this, Dr. Kass.
The same thing happens on the inside, that the tissues get more floppy. So everybody who has a risk for sleep apnea increases as they get older.
Okay, and so the risk factors. Okay, so I think this is really interesting. Like, what can happen if, in fact, you have sleep apnea? What are the risk factors to your health? So we'll talk about children. We'll talk about adults. So let's talk about the adults first. And the first thing on our list here is high blood pressure. You could have high blood pressure because of that.
Right. What happens is when you stop breathing at night and the body has a stress response, your blood pressure goes way up at night. If it happens continually during the night over many years, it increases it during the day. So there's a very strong association with high blood pressure and difficult to control blood pressure. Many of my patients come in on 2, 3, or 4 blood pressure medicines and still not even well controlled.
Wow. And it's because of the sleep apnea?
Yes, due to the sleep apnea.
Okay, so another thing, the possibility, increased risk of heart attack?
Yes, heart attack and stroke. There's a very strong association with sleep apnea and stroke. And not only, not just a minimal stroke, but a very severe stroke and even death from stroke.
And that's because of lack of oxygen?
It's not entirely clear what that is related to. A lot of it's related to the stresses on the blood vessels.
I see. Okay.
That happens.
And so also, we had talked about this a little bit earlier, arrhythmias. Okay, so it can cause an arrhythmia, a heart arrhythmia. So explain to everyone what an arrhythmia is first, and then how does that relate to sleep issues?
So most of our heartbeats are very regular. They go boom, 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 boom. On the average, the average person 70, 72 times per minute. An arrhythmia is where the rate of the heartbeat is not regular. It goes ba-boom, 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 ba-boom. It has an irregular rhythm. And one of the most common types of this is atrial fibrillation. And there's a very strong association with sleep apnea and atrial fibrillation. And in fact, it's very hard to control the atrial fibrillation. They do many procedures now to try to control atrial fibrillation, and the cardiologists have seen that it's important to find out if they have sleep apnea first, because that's an easier way to control the atrial fibrillation.
Yeah, that's so interesting. So does the sleep apnea come first and then the AFib, or does the AFib come first and then the sleep apnea?
No, the sleep apnea causes the atrial fibrillation.
That's so interesting.
Now, if you have another reason to have atrial fibrillation, the sleep apnea will make it harder to control.
Okay, so a lot of things that we read in just ordinary magazines, they talk about if you don't get a good night's sleep, you have the possibility of gaining weight, and there's more reason for potential obesity. Is that also part of the problem? That you could gain weight, you could have an obesity issue, and maybe even diabetes?
Well, I think it's a vicious cycle. If you don't sleep well and you have poor quality sleep at night, you don't have as much energy during the day.
Okay, well that makes sense. Yeah.
Right. And if you don't have as much energy during the day, it's easier to gain weight and hard to lose weight when you're not as active.
Okay.
And the more weight you gain, the more risk you have of developing diabetes.
And so are these risk factors and risk issues the same in pediatric patients, Dr. Solomon?
So there's certainly cardiovascular risk and side effects that come from prolonged obstructive sleep apnea in children, especially when that sleep apnea is severe. Most of the children that I see have behavioral symptoms that are causing concern and causing problems at school. So when you and I don't get a good night's sleep, we're fatigued during the day and we don't have a lot of energy. When children don't get a good night's sleep, instead of being fatigued, they're hyperactive. They can't regulate their behavior. That part of their brain that allows behavioral regulation is just not well rested enough to allow them to behave normally during the day. And so you're getting complaints at school and you're getting complaints at home. I also see children that have had significant weight gain over the course of a year, whether it's because of eating habits or the catch-22 that Dr. Kass mentioned, where they're not well enough and well rested enough and energetic enough to exercise during the day, and there's some suggestion that their stress hormone levels are going up, and when that happens, we tend to crave carbohydrates and we gain weight for that reason as well.
Yeah, I can understand that. Now let's talk about some of the treatment options that are available. So you address some of the surgical issues in terms of pediatric patients looking at tonsils and looking at adenoids. Let's talk about it in the adult. So what would be some of the treatment options?
Well, the gold standard is something called nasal CPAP, which stands for continuous positive airway pressure. So if the problem is the airway is collapsible, nasal CPAP is just a fancy air blower that blows air into your nose and or your mouth that pressurizes your airway so the lung can't suck it shut. And that's the gold standard.
Okay, so, and we've actually brought samples of the gold standard and examples of the gold standard. So, and this would be outside of initially looking at maybe lifestyle changes and losing weight if you need to do that?
It certainly depends on the underlying problem. You know, so the vast majority of patients with sleep apnea, the problem is obesity and being overweight. But there could be other things, you know, it could be a jaw problem or a nasal problem, but the vast majority is overweight. And for the significantly overweight, except for losing a massive amount of weight, the only real treatment is the CPAP.
Okay, so let's talk about the CPAP. Are all of these considered, all of these different devices that we have here, and we'll show them to our audience?
Well, these are the masks.
Okay.
Okay. So this is a nasal mask. So the masks come in three main styles. What I'm holding is a little nasal mask and a headgear, and the tubing which attaches to another piece of tubing, which attaches to a small machine that's an air blower.
Okay.
And it's very quiet. It's sort of like a background white noise. And this goes over the nose and pressure and blows air in. With this one, you have to learn to keep your mouth closed, otherwise the air comes out your mouth. Okay. But a vast majority of people learn to do that. They can keep their mouth closed at night.
Okay. Now, this is the one that I think that we see.
It's a little bigger
oftentimes.
one.
Yes, this is pretty dramatic.
It's a little bigger one. This one goes over. This is a one that goes over.
Is this the way it works?
Yeah, it goes over the nose and mouth. For people who have especially nasal congestion and they have in their mouth breathers, if you mouth breathe with the nasal mask, the air will come out your mouth and it won't work. But if you cover the nose and mouth and pressurize both of them, then the CPAP is effective.
Okay, so for me, I get a little claustrophobic when things are over my face.
This is not for patients who are claustrophobic.
This would not be it.
Now, we have a third type, works very well for claustrophobic patients, and this is nasal pillows here. Again, here's the hose, and this is just a thin little strap, and this just goes under the nose like oxygen cannula. It's a little smaller, and it's not obtrusive of all, and actually patients really seem to like this one because they can put it on before they go to bed and they can watch television or read. The problem with this is you can see that the headgear is not as strong, and if you're very restless at night and you move around at night, it tends to leak and come out sometimes. Right. So you have to find the mask. And these are just one example of many examples within each category. You have to find the mask that fits the patient to the best, the right size, the right shape.
Right. And I also have to ask you this question. So, oftentimes, riding around listening to the radio, there are a lot of ads for various devices, which we won't name, but they talk about somehow controlling the tongue and where it's a simpler kind of thing as opposed to wearing a CPAP. What do you think about that?
Well, some of them are accurate and good. So it depends again on the underlying problem. Okay. You have to understand what the underlying problem which is causing the sleep apnea. If the problem is not obesity, but it is, say, a small reset jaw, there are oral appliances like go in the mouth. They're called mandibular advancement devices, but they're like mouthpieces like an athlete wears, and they sort of ratchet the jaw forward, and they seem to work very well.
In some patients?
In patients who the underlying problem is mostly the jaw. Right. And then I would refer them to the oral surgeon or dentist who makes this.
Okay, so they try this. Maybe they've tried the device that you hear about on the radio first because it's easier and they don't have to go to a doctor and they order it and all of that. Okay, so then they try that and that doesn't work. So at what point is surgery necessary, Dr. Solomon?
So in severe obstructive sleep apnea, we are probably not going to cure the patient with surgery alone. In patients with moderate or mild obstructive sleep apnea, there are some surgical interventions that are going to cure even your adult patients or augment the CPAP use. So there's 3 levels of obstruction that lead to sleep apnea or obstruction at night. So if you think about your upper aerodigestive tract, you have your nasal airway, your oral airway, and then as you go lower behind the tongue, you have your pharyngeal airway. Some patients with obstructive sleep apnea can't breathe well through their nose because the cartilage in the center that divides each side is deviated and blocks one side.
So we hear about deviated septum, right?
That actually can affect your ability to breathe through your nose at night to the degree that it can cause some level of obstructive sleep apnea. Often the turbinates, which are little outcroppings on the inside of the nose, are enlarged as well. So now you have a deviated septum that's abutting an enlarged turbinate, and there's no airway there. So one of the things we can do as otolaryngologists to address nasal obstruction and sleep apnea surgically is to straighten out the nasal septum and reduce the size of the turbinates. And then as you go farther back, you're thinking about the soft palate and the oropharynx. So when you open your mouth, you'll see that little thing that hangs down in the back. That's called your uvula. On each side of that are your tonsils. And the soft palate hangs low towards the tongue. And if that space is obstructed, we can do something called a UP3 or a uvulopalato-pharyngoplasty to both remove the tonsils, remove the uvula, and tighten up that area of the obstruction so that you have a better oral pharyngeal airway. And then finally, as you move lower, you move towards the tongue base. The back of the tongue tends to collapse toward the posterior pharyngeal wall when we sleep, and it can obstruct the airway, both when you have a large base of tongue and large lingual tonsils, or you have a recessed jaw, as Dr. Kass mentioned. So there's some things we can do at that level as well, like put stitches through the bottom of the tongue and then connect them to the front part of the jaw to pull the tongue forward. We can also, and my partner, Dr. Spala, who does adult sleep medicine, can do a genioglossus advancement. The genioglossus is a muscle at the bottom of the tongue. He does a inferior osteotomy and actually moves the jaw forward. So those folks with a recessed chin or a weak chin, that is actually allowing the tongue to fall backwards. When he does this this mandibular advancement inferiorly, he actually takes the muscles of the tongue and pulls them forward so that the whole tongue moves forward. And finally, as you go a little lower, you get to the hyoid bone, and he can actually take that bone and suture it to the thyroid cartilage, which pulls the airway open at the lowest level. So there's multiple areas where we can address.
I can see that. Oh my goodness. And so does it come right down to, as I was preparing for today, does it come down to cutting away? I also see where you use laser procedures, which I thought was interesting.
So the laser-assisted uvulopalatoplasty actually removes the uvula and removes some of the soft tissue on the sides and the palate. A lot of these procedures that address the uvula and the soft palate to tighten it through scarring or removing excess tissue are more effective in treating snoring than they are in treating true obstructive sleep apnea. But a visit with the surgeon, with an ENT surgeon, is what's going to help you decide what procedure is right, in concert with the relationship with your sleep medicine specialist, Dr. Kass, and Dr. Sedke at Cooper. So it's really a multidisciplinary effort because, as you mentioned previously, there's the lifestyle changes that go along with this, and we can have them talk to a nutritionist. There's the evaluation by Dr. Kass and his team and the use of the CPAP, and then there's the augmentation of all of these interventions by the ENT specialist.
One of the other things that I thought was interesting, you talk about implanting plastic cylinders in the soft palate. I mean, my first reaction to that was, I don't know if I want anything plastic in the back of my throat. So how is that used and how effective is that?
So if you think of somebody who's asleep and snoring and has poor muscle tone during that point in the night, their soft palate, where the uvula hangs down, is vibrating as they inspire air. These cylinders that you're talking about are actually inserted while the patient's awake, and there's some really neat YouTube videos if you have the stomach for it. And they are inserted longitudinally in the soft palate, and then over time fibrosis or scar occurs, which leads to decreased vibration of the soft palate. Again, this is a procedure that's most likely to address snoring rather than the obstruction that leads to all the negative side effects of obstructive sleep apnea.
Okay, so I mean, I think you just gave us really a wonderful primer on everything that we need to know. So, do you buy into all of that? Dr. Kass?
Well, again, I think it relates to the underlying problem. And in all of medicine, you have to know what the underlying problem is to know how to treat it.
Sure.
So if the problem is obesity and the bottom of the throat is narrow, usually treatments for the mouth, surgical or oral appliances are not going to be helpful.
Right. You need to lose weight.
You need to, especially if you have significant sleep apnea. Mm-hmm. Snoring is another story. It may help people with just mild snoring, but if you have sleep apnea, you either have to lose weight or use CPAP. Mm-hmm. Sometimes, though, we have patients who are obese and need CPAP but can't tolerate it due to nasal obstruction, and then sometimes we send them to ENT for nasal surgeries to help them tolerate the CPAP.
Okay, and so what I find interesting is that at Cooper, through the Sleep Disorders Center, through the support on the surgical side, someone can be evaluated. If surgery is necessary, they can get it. I mean, so why should somebody choose Cooper?
Well, we have a lot of experience in sleep disorders, and we have a multidisciplinary approach. So you can see the sleep disorders person who can make the diagnosis. You can figure out what the underlying problem is, and you can be sent to the proper person for the treatment that best fits your needs. Mm-hmm. We make a recommendation to patients, but they have to agree. They have to be willing to undergo these procedures or use these devices.
Yeah, so it's interesting. So, reveal this. Both of my brothers have had an issue, and they have used devices, and because the devices have been used successfully, they feel like they have a new life. Is that what you're finding?
Absolutely. It's
one of the energized again?
One of the most amazing things is to change a person's life drastically. I mean, I've had patients say to me, "I'm a new person," and actually people have complained that I have too much energy.
Oh, I can't imagine that.
Isn't that amazing?
Yeah, it really is.
It's really one of the few things that I can really change an entire, think about it.
And pretty quickly, from what I understand.
And very quickly. Yeah. If you are sleep deprived due to, with poor sleep quality, I mean, just can imagine never having a good night's sleep. Never. For years and years on end.
And you don't even know it.
And you're just used to that.
Right.
And then it's like opening your eyes and seeing a whole new world.
And so, and also tell me the difference between men and women. Do you find men have more issues with this than women do, or is it fairly equal?
No, it's much more common in men, especially premenopausal women have very little sleep apnea. They have a lot of snoring, but they usually have to have an anatomical abnormality in the upper airway for them to develop sleep apnea. So it's about 10 men to every one woman premenopausally. But after menopause, women start to catch up, and it goes to about 2 to 1. It's still more common in men.
All right, so we have a number of people who are interested in getting you to answer a couple of questions for us. So let's begin with that. So here's the first audience question that we have. This woman says, pardon me, my husband snores terribly and has sleep apnea. We cannot sleep in the same room, and it's a nightmare if we go away and have to spend the night in the same room. Who hasn't been there? Can anything be done to help our situation besides booking 2 rooms at the hotel? So what do you think?
Certainly. Well, it sounds like if it's a loud snoring and she may be witnessing apneas, that there's a high risk for sleep apnea. Mm-hmm. And this person needs to become evaluated and will probably need a sleep study. Mm-hmm. If either through CPAP or surgery or an oral device, we should be able to control the snoring and the sleep apnea. So it's not only important, there are 3 problems with snoring and sleep apnea. One is, as it appears in this question, the social issue,
yes,
that it's keeping her up.
Right.
2, it's causing poor quality sleep, and the person who is having the snoring and sleep apnea is not functioning 100% the next day. And 3, the long-term medical ramifications, high blood pressure, risk of stroke, arrhythmia, heart problems, and such, and even death over time.
Indeed, okay. Another question. What are some of the non-surgical treatment options? And so would you say it begins with this?
Well, again, it depends on the underlying problem. Mm-hmm. If I have a thin person with a small jaw, I'm going to send, give them the options, right, and they may choose to go first for an oral appliance. Or if it's a child with tonsils, they're going to go see the ENT and have or an adult who's thin and have large tonsils, they're going to have surgery. If they're overweight, the chances are I'm going to recommend CPAP. Now, the problem with CPAP, if you just prescribe CPAP to somebody, and do not just send it to their house. Only about 40% of people wear it. So it gets a bad reputation as not being easy to wear. But if you spend some time with the patients, and one of the reasons to come to Cooper is we have a CPAP clinic where our patients can come in free of charge, just make a reservation 5 days a week. If they have any education, they can be refit for masks, they can be taught how to use their headgear, and if you give care and time to the patients, I find that over 80% of my patients can wear the CPAP. I commonly get referrals from other laboratories with patients with sleep apnea who can't wear their CPAP. And most of the time we can get it to wear it, but you have to have some patience.
Have to have some patience with it and,
Right.
and kind of deal with it. Okay. I think you addressed this a bit earlier. Does surgery cure obstructive sleep apnea?
So it depends on your population and how you pick the person you operate on. In the kids that I operate on, 90% of the time I'm going to fix them with a tonsillectomy and adenoidectomy. Occasionally I'm going to have to adjust their septum or reduce their turbinates, but I'm often very successful because this is a simpler problem in children. For adults, it's a harder problem to fix with surgery alone, though in select instances that can be accomplished. And again, as Dr. Kass mentioned, the skinny patient with very large tonsils and a deviated septum, we have a higher chance of success with surgical intervention. The obese patient who's struggling to lose weight, that's a more difficult problem to fix surgically.
Okay, so it sounds like we have two issues here with the snoring and with sleep apnea, because this question seems to address that. What happens if I start to snore again after having surgery? What are your thoughts about that?
So we need to figure out if that snoring is associated with apnea or not. If the snoring is associated with apnea, then we need to address the apnea through a sleep medicine evaluation and potentially CPAP or additional surgery. If it's snoring alone, the oral appliances or devices may be helpful, or some of the other augmentation that we do surgically. So in a select patient, there's usually more than one surgical option to address their issues.
Okay, here's another question. I find this interesting. I can never sleep through the night. I always wake up around 3 a.m. after falling asleep after midnight. What do I do to sleep longer? So
well,
let's address
this
that.
is a different problem. So this is a disorder of maintaining sleep. The lay term would be insomnia.
And even when you just wake up at 3 o'clock, you consider that an insomnia?
Well, if you can't, especially if you can't get back to sleep.
That I would understand.
Well, if you get up at 3 o'clock and you roll over and you go back to sleep, that's not a problem.
Okay.
If it happens many, many times throughout the night, it can be a problem. Or if the most common issue is you get up at 3 o'clock and you start thinking about things, and your mind is going.
I've been there.
Right,
Yeah.
we all have. Yeah. Especially if you have stresses and anxieties going on in your life. So this is a problem of insomnia. It's a different problem than sleep apnea, though they can happen in the same person sometimes. And I think the first thing you have to figure out, is there a simple lifestyle problem or a medical problem that's causing this? I mean, are you drinking too much fluid in the evening before you go to bed and having to get up to go to the bathroom a lot at night, especially as you get older? Are you drinking caffeine in the evening? And especially, people don't realize that iced tea in the summertime has caffeine. And that you may be able to fall asleep, but then when you wake up, you're wide awake.
Right. I mean, alcohol is an issue too,
Alcohol is another issue, right. Alcohol will let you fall asleep, but then when it wears off, you tend to wake up. And things like that. However, if it's none of these, and it's just where your mind is racing, then you have to address that. And that's a much more difficult problem, because that's a behavioral problem. And we work with the patients. We have with better sleep hygiene, which means better sleep habits, trying them to get used to going back to sleep with different techniques. We refer them to psychology for therapy and different modalities for relaxation, for trying to go back to sleep. And the last thing would be medicine.
Right. And postmenopausal women often have that issue
yes.
too,
With
getting up because of hot flashes, or
they have hot flashes.
A lot of other things that are
Yes.
going on in their minds at the time. Okay, so what is the relationship between sleep apnea and AFib, the atrial fibrillation? We addressed that a little bit, but let's give a little more detail on that.
Okay, so when you have sleep apnea and you stop breathing at night, the brain sees that you're not breathing, and you have a big adrenaline rush. And these hormones make the heart race. So if you have a tendency to have your heart race or become irregular, this exacerbates it tremendously. So it could be someone who they could have the same risk factors, and one person doesn't have sleep apnea and they do not develop atrial fibrillation, but the person with sleep apnea, because of all this extra stress on the heart, will develop atrial fibrillation. And once they have atrial fibrillation and sleep apnea, if you don't treat the sleep apnea, it's very difficult to control the atrial fibrillation.
Is there a relationship between sleep apnea, AFib, and dementia, or sleep apnea and dementia? Have there been
Well,
any
not atrial
connections with that?
fibrillation and dementia, but sleep apnea and dementia, because specifically sleep apnea and memory. If you think about it, even normal people who have a bad night's sleep because they're up doing something, the next day, your memory's not quite as good.
Right, you're foggy.
You're not firing on all cylinders. If you have an underlying problem with memory and you put a sleep problem on top of that, it makes it worse.
Okay. One more question here. What causes me to kick and swing my arms and body while asleep? I hadn't heard that before.
Well, actually, this is quite common.
It is?
But you're really talking about two different things.
Okay.
So the first thing is the kicking or the twitching of usually of the legs.
Kind of involuntary?
Involuntary,
Yeah.
but usually the legs, but sometimes the arms. This is called periodic limb movements. Not just legs, because sometimes it happens in the arms. And this is a very common problem. And it's caused by multiple problems. Actually, snoring and sleep apnea cause it. Iron deficiency causes it. Neuropathy, where there are patients with diabetes, you can see this. And in some patients, it doesn't bother them at all. But in some patients, it causes them to have difficulty sleeping and causes them to have poor quality sleep. Now, there's a separate issue is when you have movements in your sleep. In fact, the lay term would be like acting out your dreams. There's a disorder where normally when we sleep and we dream, there's a message sent from the brain to our muscles not to move. We're sort of, the muscles are sort of paralyzed, so we don't act out our dreams. In this disorder, the message is not sent, and our muscles are active. So say you're in your dream and someone's chasing you,
Right.
you get up and run, but you're in your dream, so you get up out of your bed and run, and you run into the wall.
Oh, wow.
It's called REM behavior disorder, and it's much more common as you get older and much more common in men.
It's fascinating.
The bad thing about it is that you can hurt yourself. The good thing that
You
it's
can hurt somebody else also
Well, right,
who
or
might
punch.
be in bed with you.
I've seen, people, 80-year-old people married 50 years, 60 years, and the wife is coming, we're married all these years, and he's hitting me, he's beating me up in my sleep.
Wow.
And the good thing is that it's easily treatable with medication.
That's good to know on that one. Okay, so I can't, here's something else. I can't tolerate the CPAP mask, and we talked about that just a little bit, and have had surgery. What are other options? Does it try different styles of mask, maybe?
Well,
Or if you can't handle a mask, you can't handle a mask.
First I'll go, if it hasn't been through my laboratory and through my CPAP clinic, I'm going to go try another try. Because there are new masks, and just another one just came out very recently. That's a combination of the nasal and the pillows. So there are new masks all the time, new sizes, and I will try much harder to get the patient to wear it. If not, we can look at an oral appliance. If they're not overweight, even if they had surgery, they can go back and have a re-evaluation by the ear, nose, and throat surgeon.
And so, Dr. Solomon, for one more word from you. So if I'm a mom and I'm hearing my child snore at night, should that really be a signal to follow through and really talk seriously about what's going on with my child?
Yeah, I think the mom that observes their child at night snoring needs to put it in the context of, have they had a recent upper respiratory tract infection? Because with increased nasal secretions and the swelling that occurs in the tonsils in the back of the throat, you can have snoring that's temporary. It might last about 6 weeks and then resolve. Is it a child that's snoring all the time and has been for months or years? Have they observed apneas? Almost all my moms that have children with obstructive sleep apnea are observing the children snore and then stop breathing at night to the point that it's making them anxious. And then they're having some behavioral symptom during the day. So whether that behavioral symptom is they're difficult to wake up in the morning, or they're hyperactive, or hyperactive and fatigued during the day, that constellation of symptoms should alert us. And I think the point you make, that snoring alone should alert us to observe more closely. And if there's a question, to have an evaluation.
All right, gentlemen, thank you so much. What an interesting
you.
discussion, Dr. Kass, Dr. Solomon. Always lovely to see both of you. I'm Pat Shiraki. Thanks for joining us.